We are so glad you have joined us this evening. Welcome to the third episode of UT Southwestern Science Café. For all of the regulars, welcome back. And for our new guests, we are so pleased to meet you. My name is Jenny King, and I'm Director of Public Affairs here at UT Southwestern. And on behalf of my colleague, Corey Tobian, and our guest speaker, Dr. Prasanna Alluri, thank you for joining us tonight. Science Cafés are online conversations where speakers take you on deep dives into science topics. The format is casual and interactive, and our speakers are UT Southwestern faculty and occasional invited special guests. We encourage you to ask questions and engage with us during the program. This evening, we will be discussing breast cancer, bench to bedside, the interface of clinical oncology and research. Thank you in advance to UT Southwestern Harold Simmons Comprehensive Cancer Center Assistant Professor, Dr. Prasanna Alluri, for joining us this evening. In recognition of October being Breast Cancer Awareness Month, Dr. Alluri is going to take us on a deep dive into the science behind the interface of breast cancer treatments and research. Before we begin, as usual, there are technical matters to briefly mention, and I'm going to tell my family to be quiet. I am so sorry, but that's what happens when you have live Zooms in the evenings. So before we begin, here are our technical matters. Like the family, please mute your microphones to help with audio clarity for everyone. Just unmute yourself if you are called to ask a question. We encourage you to utilize the chat feature to list your questions for Dr. Alluri. We will call on audience members to ask those questions following their joint presentation. Corey is going to be facilitating our Q&A. And just a reminder, we are not able to answer personal medical questions, but we would absolutely love to hear from you with your general questions. And with that, I am very pleased to introduce our presenter. Dr. Alluri is a physician and a scientist in our Simmons Comprehensive Cancer Center with expertise in both research and clinical care, and he brings a unique combination of skills to his patients and his colleagues. His clinical focus is on breast cancer, where he sees the entire spectrum of breast cancer patients, from newly diagnosed early stage breast cancer patients seeking curative treatments to metastatic, I didn't say that right, breast cancer patients looking for innovative clinical trials. Dr. Alluri also directs a research laboratory that's focused on understanding the molecular mechanisms of treatment resistance in breast cancer. Dr. Alluri, welcome to Science Cafe. The virtual podium is yours.
Thank you so much, Jenny. This is a real pleasure to be a part of this forum. I see Stu, who I know all the way back from grad school. So this is truly a pleasure. I trained at UT Southwestern, got my Ph.D. here before I went away for my clinical training, and I couldn't be more excited to be back. I've been here for the last 3 years or so. And as Jenny has mentioned, I focused in treating patients with breast cancer and also direct a research lab where we study why some patients, especially those that have aggressive forms of breast cancer, don't respond treatments as well as other patients do. And we are trying to come up with better ways to treat them. Let me go ahead and share my screen so that we can get started. Looks like it's taking a second to load. All right, can you all see my screen? Perfect.
Yes.
Let's get warmed up with a question, actually. So how many women are diagnosed with breast cancer every year in the US? While you're thinking about it, taking the survey, the first time this struck me was first week of medical school. Our class was about 150, half of them men, half of them women. And one of the classes, one of the professors told us, hey, there's about 75 women here and 10 of you in this room will develop breast cancer. That was uh, that struck me. We were young in medical school and thinking a lot of stuff, and then to realize that 10 of my colleagues will go through breast cancer was a pretty stunning. All right, looks like we have a winner there, and I think the audience picked the right answer. About 250,000 patients are diagnosed with breast cancer every year. We lose about 40,000 patients every year, so it's a huge, huge burden. Globally, about 2 million cases and 500,000 deaths every year. So it continues to be a huge source of mortality, both in the US as well as globally. If I can advance here. There we go. Having said that, one of the most gratifying things is that the mortality from breast cancer over the last 30 years has been coming down quite significantly. So we have made a lot of progress across multiple facets of treating breast cancer, especially in the diagnosis. As you all know, mammography has significantly improved detection of breast cancer. So we're able to pick up cancers a lot earlier than what we used to before. All facets of treatment of breast cancer, from surgery to radiation to systemic therapies, have improved quite dramatically over the last 20, 30 years. And this is reflected in significant improvement in outcomes for patients with breast cancer. Having said that, if you look at a patient who we may see in clinic, a lot of these patients have very early stage breast cancer thanks to mammography. So when we see them in clinic, typically when we examine them, we may find a small lump in the breast. Some of them are not even palpable, so this may have been an abnormality on a mammogram. And the rest of the exam is usually normal. There's no evidence of any cancer in the lymph nodes or in the rest of the body on clinical exam. And also we do ultrasound to look at lymph nodes if there's any morphologic evidence of abnormality. And a lot of these patients, they all look normal. And these patients, the risk of having metastatic disease, that is cancer spreading to outside the breast to distant organs, is so low that we don't even do any additional scans like a CT scan or a PET scan. In spite of that, in reality, these patients actually have microscopic disease that is more extensive than we can appreciate on any clinical exam or a scan. So these patients may have microscopic disease in the rest of the breast outside the original lesion that led to the diagnosis. They may have cancer cells in the lymph nodes, even when you don't see any abnormalities on an ultrasound. They may have cancer cells in the rest of the body, distant organs like liver, bone, lungs. They're so tiny that none of the exams we have right now, even the most sensitive tests we have, do not pick them up. And the success of breast cancer today has really come from the realization that it is not a local disease. This is what we call a systemic disease. Even though you may have a tiny little mass in the breast and everything looks completely normal, a successful treatment involves treating 3 different areas, or at least addressing 3 different areas. Obviously, we have to address the cancer that's in the breast. We have to address any potential cancer, even when we don't see any evidence of the cancer being present in the lymph nodes. And also we have to address any potential occult disease anywhere else in the body. As you all, before we go there, so again, let's take another survey for a let's say a newly diagnosed breast cancer patient, let's say with stage 1 disease, which is only cancer that's confined to the breast without evidence of any disease in the lymph nodes or anywhere else, that is fairly small. What do you guys think is the 5-year survival for a patient like that? Very close. So turns out the 5-year survival for patients with stage 1 disease is well over 90%. It's actually close to 100%. So this is again a testament to how far we have come in treating especially the early stage breast cancer. Now, that is just the average. There's still some patients, even with stage 1 breast cancer, especially different subtypes of breast cancer, which I'll get into a little bit later, that may have a little bit worse survival. But by and large, for this very early stage breast cancer patients, we do an exceedingly good job. Again, a lot of this is related to the fact that we're able to pick them up very early from screening. The fact that we address this through a multimodal fashion, not just surgery, which used to be how these patients used to be treated, but all modalities of therapy, including, in addition to surgery, radiation and systemic therapies, which have really improved dramatically over the last few decades. And for patients that have spread of the cancer to the lymph nodes, the 5-year survival on an average is still very good, in the 80, well over 80%. Again, there's a huge spread there, but this is just an average. And the one area where we still do quite a poor job is in patients that have stage 4 disease, that is patients who have cancer that has spread distantly to other organs like bone or liver or lungs. In those cases, our survival is still, at 5 years, is only about 25%. Again, there's a huge spread. There's some patients, especially with favorable types of breast cancer, who are alive sometimes even 20 years after being diagnosed with stage 4 disease. So we are making progress every year. But even with that, I think there is a long ways to go. 2 months ago, I had a patient who was 34 years old, who had progressed to every treatment we gave her, and I had to say goodbye to her. She went to hospice and died a week later. And in 2020, for a 34-year-old patient who came to see us with stage 3 disease, and over the next 18 months progressed through every single treatment we gave her. So we have a long ways to go, although we do a really good job with early stage breast cancer. So as many of you know, before we had the benefit of treating breast cancer with multimodal treatments, the primary treatment for any kind of breast cancer used to be radical mastectomy, which is removal of the breast, the underlying muscle, all the lymph nodes. This was a technique that was pioneered by Dr. Halstead, who is clearly way ahead of everybody else back then, because he understood that treating breast cancer does not involve just removing the tumor in the breast. So clearly, although we didn't have any imaging modalities to help us, although there were no additional help from systemic therapies like chemotherapy or radiation, and also because there was no screening, all the cancers that were detected back then used to be very advanced, large tumors that were invading the chest wall. So that required this realization that it's not just enough to take out this tumor, you have to go way beyond to address all the microscopic disease. And even with this fairly radical, very disfiguring surgery, the survival still used to be horrible. The reason for that is, again, we didn't have any systemic therapies to take care of microscopic disease or even gross disease, because we didn't have any imaging back then. We didn't even know that they had stage 4 disease, and the outcome still used to be quite poor. The fact that now we have patients that are living with a survival of 99% at 5 years, especially for early stage breast cancer, with a treatment that is way more, less invasive, relatively smaller operations, breast preservation in a large number of patients, a lot of options for reconstruction as needed, a lot of help from additional modalities like radiation, systemic therapies, that that these patients can have their lives back with especially such good outcomes is again a testament to the fact that we work together across different teams and identify the fact that breast cancer is not a local disease. Even in the case of stage 1 disease, this is really systemic disease where we have to address the cancer in the breast, any cancer in the lymph nodes, and any cancer, microscopic cancer outside of breast and lymph nodes. So let's talk briefly about how we moved away from this radical mastectomy or even mastectomy in a large number of patients. That came from an interest, obviously, in providing patients options to give less invasive and less disfiguring options. But at the end of the day, the goal is still to treat the cancer effectively. That still is the number one goal. And there were a number of trials that looked at potentially sparing the breast, that is not to do a mastectomy, but to leave the breast behind and only take the portion of the breast where the cancer is. And a number of studies across many countries, across tens of thousands of patients. And what all of those studies have shown was that if we do this limited operation where we just remove the tumor and leave the rest of the breast behind, that is, leave the breast as long as we do the rest of the breast with radiation.
Stop you for a second, Dr. Alluri. We can all make sure we're muted. Thank you.
As long as we gave radiation to the rest of the breast, those patients lived as long as patients who had a mastectomy. And that makes sense because as I had previously mentioned before, even when you only see a small tumor, oftentimes there's microscopic cancer cells that you can't see on any scan or on any exam. And what radiation is doing is going after these microscopic cancer cells and killing them so that we are able to preserve the breast. So that kind of led to a very wide adoption of breast preserving approaches where virtually or nearly all women who are candidates to have this limited operation of just removing the tumor opt to have this limited operation followed by radiation to the rest of the breast. So this is again reinforcing the same concept that even after we removed the cancer, visible part of the cancer, there's still some microscopic cancer cells. The next thing we have to worry about is the patterns of spread of the cancer beyond the breast. So the most common site breast cancer spreads to outside the breast is to lymph nodes. So lymph nodes are essentially a collection of immune cells, and their normal function is to kind of surveil the body, looking for microbes and things like that, and to clear them. And these lymphatic channels can also serve as a channel of spread for cancers. So for breast cancer, the most common location it spreads to is to lymphatics in the axilla or the armpit area. In addition to that, there's also some lymph nodes above the collarbone called the supraclavicular lymph nodes, and also next to the breastbone called internal mammary lymph nodes. So when breast cancer spreads, there's a potential for the cancer cells to spread to these lymph nodes and then from there to the rest of the body. So even in cases where we do not see any evidence of cancer having spread to these lymph nodes, we still have to somehow assess whether there's any microscopic or even more than microscopic cancer in those lymph nodes. And we can't just rely on imaging modalities because they do not have 100% sensitivity for picking up all the cancer in the lymph nodes. So again, going back to the olden days, virtually every patient diagnosed with breast cancer used to have all of their lymph nodes removed, no questions asked. The reason for that is, again, there's no way for us to tell reliably how many of these patients have cancer in the lymph nodes, and we can't just leave them behind and take the chance of the cancer spreading and progressing to stage 4 disease, at which point it is not curable. So all of these patients used to have all of their lymph nodes removed, no questions asked. And that had, a significant side effects. One of them is what's called lymphedema, which is swelling of the arm, which can be permanent and there was an interest in moving away from these, debilitating invasive procedures. And one of the biggest advances that really changed the landscape of treating cancer in the lymphatics is the advent of this procedure called Sentinel lymph node biopsy. This is a very, very nifty procedure. Essentially, it's done in nearly all patients that have breast cancer that don't have any clear evidence of cancer on any imaging. The way this works is the surgeon at the time of surgery, I should say, injects a blue dye around the tumor. And this blue dye is picked up by the lymphatic channels. And it turns out that when the cancer spreads from the breast to these lymphatics, it does not spread randomly to any lymph node. It spreads to one lymph node called the sentinel lymph node. And from that lymph node to the second, third, fourth, so on and so forth. So this is more of a serial spread rather than random spread to a number of lymph nodes at the same time. What that allows us to do is if there's a way for us to find out what the sentinel lymph node or which lymph node is the sentinel lymph node, then we can just remove that one lymph node or the first couple of lymph nodes where the cancer would have traveled to, send it to the pathologist who will essentially slice this lymph node into tiny slices and look under the microscope to see if there's any evidence of any cancer in the lymph nodes. And if there's no cancer there, then you're done. You know that the cancer has not spread. And the analogy I often tell my patients is this is like you're driving through a highway that is the only path you can take, and there are exits along the way. And what we're doing is we're standing by exit 1 and exit 2, and we're kind of looking for the person we're looking for to pass. And if the person hasn't passed exit 1 and exit 2, we don't have to look at exit 3, 4, and 5 because this is the only path they can take, and we can say with confidence that they have not passed and we can move on. On the other hand, if we go and take out the sentinel lymph node 1 and 2, if there's any cancer there, then it means that the cancer has already spread to the lymph nodes, and we have to do something about it. We have to figure out a way to treat it. So this has essentially this innovation now has spared nearly 85% of these early stage breast cancer patients who were previously getting removal of all of their lymph nodes, this very not disfiguring, but debilitating surgery of removal of all the lymph nodes. So we're sparing 85% of the patients. So that means about 15% of the patients who have no evidence of cancer on any imaging still have cancer in the lymph nodes. And those are the patients where we have to address that somehow, which I'll get back to later. So this again was a significant advance. And again, going back, we were going from a radical mastectomy of removal of the whole breast and the underlying muscle. We moved away from that. Then we were doing mastectomies, simple mastectomies, where we were sparing the muscle but removing the whole breast, and also removing all the lymph nodes because we did not know any better. We had no way of determining if the cancer has spread to the lymph nodes, to now doing a very limited operation where we're only taking out a small portion of the breast where the cancer is. And again, doing this very nifty procedure that tells us if there's any spread of the cancer to the lymph nodes, and spare this aggressive operation in 85% of the patients who do not have any spread of the cancer. So the next thing, of course, going back, so this patient, let's say, had their tumor removed. We know that there's still microscopic disease in the breast. Let's say they had a sentinel lymph node biopsy and she happened to be one of those 85% of the patients. There was no spread of the cancer to the lymph node. So we can say we don't have to worry about treating the lymph nodes because there's no cancer there. And then obviously we still have to address the microscopic disease in the breast, and the way that is done is with radiation therapy. And as I have said before, what radiation does is it kills the microscopic cancer cells in the breast, and essentially at that point completes the local regional treatment of breast cancer. However, there are some challenges here, especially for patients that have left-sided breast cancer. The heart is right behind where we're treating, right? So even with the contemporary advanced radiation approaches we have, when the very front part of the heart is right behind the chest wall, essentially touching the chest wall, it's very hard to completely avoid the heart and treat the whole breast. because we're trying to treat the whole breast and kill all the microscopic cancer cells there. So unfortunately, for a number of years, we didn't have a choice. And we used to still treat the whole breast, and a small portion of the heart was used to receive radiation. And we knew that that would cause some increase in complications, but not high enough that it offsets the benefits of treating the cancer. And like a lot of times in medicine, we have to take some risks to get the benefits. But then since then, again, we have advances. We've gotten better, where we are able to do a much better job. So what we do now, this is something we do routinely in all left-sided breast cancer patients, is what we call deep inspiratory breath hold. What this does is, imagine if, this is the chest wall, the breast is on the outside, and this is the heart. So the heart is right behind. What we make the patients do is take a deep breath and hold. What that does is, when you take a deep breath and hold, it expands the chest wall and moves it away from the heart just a couple of centimeters, not a lot. But that creates us enough space to treat the whole breast and spare the heart. What I'm showing here, by the way, this is not a patient, this is one of our radiation therapists who's demonstrating this. So there is this spirometer, and when they're breathing, it shows them their breathing pattern. So when they take a deep breath, when they're breathing, this is essentially the volume in the lungs. It goes up. When you let go, the volume in the lungs goes down. And then we ask them to take a deep breath, and there are some targets that are set. So they're able to watch this on a monitor, and then we tell them you have to take a deep breath until you reach this green bar. We know, based on CT imaging, that depth of breath hold gets the heart away enough for us to avoid the heart, but still treat the breast effectively. So we do this at 30-second intervals. So usually when we treat breast cancer, there are two what we call tangents. One that's coming from medial is what we call, and another beam coming laterally to treat the whole breast. So we ask them to, again, do this. They have a monitor in front of them. They know the depth of the breath hold they have to do, and they hold their breath for 30 seconds. And the treatment only goes on for those 30 seconds when their breath is on hold. And we're able to do this very safely. And if for any reason the patient got short of breath or something, and as you can see on the bottom right, if the breath hold falls below the threshold, that automatically stops the machine. So even if there's an error, we are still able to treat them very, very effectively, again, sparing the normal tissue toxicity while being very effective in treating their cancer. This is one of the advances that is a little bit more recent, and this is something we do very routinely at UT Southwestern. So going back to the paradigm we're talking about, so this is a patient who had surgery before, had the tumor removed. As we said, the patient did not have any cancer on the lymph nodes, so we didn't have to treat the lymph nodes. And the patient obviously still has microscopic disease, and we treated them with radiation. So a typical treatment with radiation for a patient like this is about 4 weeks, 4 weeks of radiation, once a day, 5 days a week. So we're talking about 20 total treatments. The reason why we have to do this over such a long time, in fact, it used to be over 6 weeks, and there's some additional studies that showed us that we can do this in as low as 4 weeks quite safely. The reason why it takes us 4 weeks and not just in one session is related to the fact that when we're treating the breast here, we're primarily treating the normal breast tissue, right? There's some microscopic cancer cells, but they're like very, very, very small fraction. So we're really treating the normal breast. If you give a very high, in fact, we can give all of the dose that we're giving in 20 sessions in one session, but the problem is that's going to cause a lot of toxicity. It's going to kill a lot of the normal tissue. So the principle we take advantage when we treat cancer with radiation is the fact that radiation causes damage to the DNA. That's the principle by which it works. The advantage we have is that the normal cells have an ability to repair the damage, whereas the cancer cells have a defect in their ability to repair the damage. The reason for that is they're dividing very fast, so they're using up the machinery that's needed for them to grow fast, so they can't deploy some of the same proteins that are also involved in DNA repair. So they're very erratic, they're just being very fast, and and they can't fix the damage that the radiation induces. So what we do is then we give a little bit of a dose at a time. So you give a small amount of radiation on day 1, and you give them 24 hours to recover. What that does is the normal cells, they repair the damage. The cancer cells, because they have a defect, stay injured. So you come back on day 2, give them another hit. Again, both the normal cells and the cancer cells get hit, but you give them another break of 24 hours, the normal cells recover, the cancer cells don't recover. You do this over and over again, and by the end of the treatment, the cancer cells are injured enough that they actually die, whereas the normal cells, even though they have some mild injury, are able to recover. This is what you see with redness of the skin, some of the side effects you see, but all of that goes away and the normal tissue makes a recovery. So that's the principle behind treating these cancers with radiation. So we do this over 4 weeks, typically 20 treatments. Now, that is the standard of care. So the standard of care right now is for a patient with early stage breast cancer, we give them about 4 weeks of radiation after they have surgery. There is now, I'm going to talk about some of the very exciting advances that are happening now that is changing this paradigm. So there is an interest in a newer modality of radiation called partial breast radiation. The concept here is that, I previously showed you that there is some microscopic disease in the breast, even after you have removed the tumor, and you are treating the rest of the breast to kill the microscopic disease. And what we do in partial breast is that we don't treat the whole breast. It turns out, this is not for all patients, for some carefully selected patients, it turns out that most of the risk of microscopic disease in the breast is around where the tumor used to be, about a 1 centimeter area around where the tumor used to be. So this led to the question, do we have to treat the whole breast, at least in a subset of patients that have favorable risk breast cancer? Can we get away with treating a smaller area? And what we do is, this is the tumor, as you can see on the left, but when the surgeon goes in and removes it, they leave behind what we call a surgical bed. The surgical bed tends to be much bigger than the tumor. Even if the tumor is only 1 centimeter, the fact that they have to go through the scan, they have to scoop out that whole tumor, it ends up being, much bigger. Sometimes it could be as big as 3 centimeters. Again, depending on the location, how far, deep they may have to go to scoop it out, so on and so forth. Now, we put a margin around this surgical bed because that's where the microscopic disease is. So we have to expand it beyond where we see the surgical bed. And then, because the breast is a mobile organ, right, when these patients are lying on the treatment table, there can be a little bit of, change in the way the breast sets up day to day when we're giving radiation. So you have to account for that. If you don't account for that, you're going to miss the target. So we put an additional margin, typically about a 1 centimeter margin, to account for any setup uncertainty of the breast. And then we treat this whole area. So this now is what is called a partial breast radiation instead of whole breast radiation. What is the advantage of this? The advantage of this is you are now exposing a much smaller portion of the breast to radiation and sparing the vast majority of the normal breast tissue, which means you can actually now give a much higher dose during each of those treatments without having to worry too much about toxicity, so much so that we can actually now go from 20 treatments or 4 weeks of treatments to as low as 10 treatments or even 5 treatments. So this is, again, quite helpful in a number of ways. One, we're not treating the whole breast. We're exposing less amount of normal tissue to radiation, reducing side effects. We're increasing the convenience of the treatments for patients, doing 5 treatments versus 20 treatments. So this is something that is catching, it is becoming more popular, and this is something we do quite often at UT Southwestern. The next thing was, well, can we do even better? So as I said, I talked about the 2 expansions we do to treat the breast. One is to account for the microscopic disease outside of the surgical bed. There's nothing we can do about it, right? The microscopic disease is a microscopic disease. We have to treat all of that. But one place where we could probably make a further advance is, is there a way for us to shrink this margin? If we give a 1 centimeter margin here versus, is there a way for us to shrink that margin so that we're treating an even smaller volume of the breast? And that came through additional technologies where we can actually completely immobilize the breast. So this is where we place an inner cup around the breast, and this actually, we apply suction, so the breast is completely immobilized. And there's an outer cup. This outer cup has a stereotactic frame so that we can track the breast very precisely to a, essentially to a millimeter precision. And this allows us to reduce this expansion from 1 centimeter to a couple of millimeters. And we also have some newer technology that allows us to treat this area with very, very high degree of precision. So there is a breast-specific stereotactic radiation device called GammaPod. We're one of the only 3 places in the world that actually has this. And what it does, again, is completely immobilizes the breast, reduces the margins further, and able to treat this with millimeter accuracy. Now we are able to, again, spare a lot of the toxicity associated with treating normal breast tissue where there's no cancer, and then limiting that high-dose radiation to really a much, much smaller area. And what that does is, one, it reduces toxicity, also reduces the treatment time and comfort for the patient. This is an example of how on the left is where we're treating the area with only a 2 millimeter margin. So you can see this treats a much smaller area, versus when you treat it by the traditional approach where you have to put a 1 centimeter margin, that ends up treating a much larger area of the breast. So this shows how much more breast we are sparing. And also the other advantage with this approach is the patient is actually lying on their belly. So the beams are going perpendicular to the breast, so any exposure to the heart is really non-existent. So these are some of the advances that we are adopting to not only improve the efficacy of the treatments, reduce the treatment time, but also improve comfort for the patient. The question then is, can we do even better? So we talked about shrinking the outer margin, right? So the outer margin previously was 1 centimeter. Now we reduced it to 2 millimeters because we're able to immobilize the breast, and also we're able to treat this with very lot of high precision. The question then is, can we shrink the inner margin? So as I told you before, the reason why the inner margin is higher is because when the tumor is removed, the surgical bed tends to be much bigger than the tumor. Again, because the tumor is not right next to the skin, so the surgeon has to go from the skin surface all the way to where the tumor is, scoop it out. So in the process, that leaves behind a large bed. So there's a much larger area that you have to now target, because the microscopic disease can be anywhere in the bed plus a 1 centimeter margin. And then the question then is, can we shrink that? And this led us to this concept of saying, hey, what about we treat before surgery? There's no reason that we only have to treat after surgery. So we are now have a very exciting trial where instead of treating after radiation, at the end of the day, the goal of radiation is to kill all the microscopic disease. Whether you do it before surgery or after surgery is really of no relevance. So we are now treating these patients before surgery. So now there's no surgical bed. All we have to do is to put a small margin around the tumor, because as I said, in these patients, typically the microscopic disease is within 1 centimeter of the tumor. That's all we cover. And then the outer expansion is only 2 millimeters, again, because of the fact that we're using this immobilization and very advanced targeting. Now that the volume of breast we're treating is even smaller, significantly smaller. And it's hard to appreciate sometimes, because the volume is a function of the cube of the radius or the diameter. So if the radius of the tumor is 2 times less, when you cubed it, it ends up being a huge difference in the volume. You're talking about, we may have to treat 100 cc of the tumor when we're treating after surgery. If you do that before surgery, we're talking about 25 cc, so like 4 times smaller volume than what we were doing before. So again, this gives us an opportunity to spare most of the breast from any harmful effects of radiation. But what this allows us to do now is, because this volume is so small, we are able to treat this in a single fraction. Remember, I told you the reason why we can't do this before is because we're treating the whole breast. We can't give high doses of radiation to the whole breast because it's going to cause a lot of injury to the normal tissue. Here, we're treating a very small area, and most of the treatment is to the tumor. So now we can get away with not having to worry about, high dose. And with the technology we have, we are now treating with a single dose before surgery. So essentially it's replacing 4 weeks of radiation, sometimes 6 weeks of radiation, with one session for the patient, and spares this patient of all the radiation to the rest of the breast, radiation to the heart, and all the other structures. So we are one of the only few institutions in the country and even globally to do a trial like this. One of the exciting things for us is, so again, remember the goal of radiation is to kill microscopic disease that is left behind after surgery. But the question is, if we're able to give such high doses of radiation, hey, what if we just completely eliminate the tumor? And do they even need to have surgery? And one of those opportunities came through because one of my colleagues had a patient who was too sick to have surgery. She had a lot of other medical morbidities. She was found to have a small tumor in the breast, and she was not a candidate to have surgery. And we said, we have a trial ongoing for treating patients, who will have surgery. But we discussed it at the tumor board, and the consensus was that, hey, not treating this patient is not an option, or at least not a good option, because if we don't do anything else, this tumor may progress and eventually cause a threat to her life. So we treated this patient with a single fraction of radiation, and this is an ultrasound. These images are hard to understand, but what you're seeing here with the arrowheads is this dark area is the tumor. And this is a clip that was placed next to the tumor. And this is it 3 to 4 months after treatment with the single fraction of radiation. This area where this tumor used to be is now completely gone. So she had a complete radiographic response. So this got us very excited. And of course, we have all the rest of the patients who are candidates to have surgery are still going to have surgery, and we'll have an opportunity to see what the response of radiation, the single fraction of radiation in these patients is. And we can perhaps imagine in the future where if this technology becomes so effective that we're able to eliminate all the cancer with radiation alone just with one session, imagine what it'll do to the whole treatment paradigm. So right now, what we do is, patients have surgery and then get 4 weeks of radiation, to saying, eliminate all of this and just have one single fraction to a very small area of the breast that spares a lot of the toxicity, no surgery, and all of that. Again, this is nowhere close to prime time. Having said that, there is precedence for that. This is not as crazy as it sounds. So Dr. Timmerman, who's the vice chair of the Department of Radiation Oncology, is the person who invented this, what we call SABR, or stereotactic ablative radiation therapy, this whole concept of being able to deliver very high doses of radiation with a high degree of precision. And he has shown this in lung cancer patients. Lung cancers tend to be way more aggressive, a lot more aggressive than breast cancer. And as the screening for lung cancer, picked up, we were, seeing a lot of patients that have early stage lung cancer, which was unheard of before. 1 centimeter, 2 centimeter, lesions in the lung. And he has shown that those patients, when treated with radiation alone, just like we're doing here, the control rates just with radiation was over 90%. This is like unprecedented. Just imagine what the patient normally would have to go through. These are patients that are a lot of times have, long-term smokers for 30, 40 years. They have very poor lungs. Normally, they have to have an operation, intubation. Previously, they used to have their chest split to have the, this lung cancer removed. We don't do that anymore. They're less invasive operations. Nevertheless, they have to get intubated, anesthesia, an operation, ICU stay. And these patients, Dr. Timmerman was able to treat with the radiation, no anesthesia, no invasive. All they have to do is lie on the table for 15 minutes, and the control rates are over 90%. In fact, he was able to treat a lot of patients who are not even candidates for surgery. They're so sick, their lungs are so bad that they're not even able to have surgery. And he was treating a lot of those patients and getting control rates of over 90%. That has completely changed the paradigm for treating early stage lung cancer. And that happened at UT Southwestern. So this whole technology of stereotactic ablative radiation is something that was pioneered at this institution by Dr. Timmerman, and this is actually has been adapted all over the world now, and we have a lot of physicians who come for training to UT Southwestern for this. So this is not as crazy as it sounds, and we are very excited to find what our trial where we're treating now breast cancer patients with a single fraction of radiation and see what their response at the time of surgery is. So going back to the patient, so
Dr. Alluri, I'm so sorry. I'm going to interrupt you for just 1 second. We have about 3 minutes to wrap up so that we can get to some questions.
All right, sounds good. So this patient, obviously had. Let's go back to the traditional treatment paradigm. This patient had surgery and then had radiation. So the radiation killed all the microscopic disease. The question is, are we done? The answer is no, we're not, because as I said before, let's see if I can advance. Looks like my slides are stuck for some reason. There we go. So breast cancer, even at the earliest stages, is a systemic disease. So this requires still a systemic therapy, something that you take as a pill or as an infusion that goes everywhere in your body and kills the cells. Again, I think we're running out of time. One of the biggest advances in breast cancer is the fact that we now have realized that all breast cancers are not created equal. There are different kinds of breast cancers, subtypes of breast cancers, and each of these different subtypes of breast cancers are driven by different drivers, meaning some of the cancers are driven by estrogen in the body, some of the cancers are driven by cell surface receptors called HER2, so on and so forth. And all the basic research advances that have happened allows us to determine which patient has which driver. So we're able to treat these patients with very high degree of effectiveness, with very less side effects. In a lot of cases, even avoid chemotherapy. So this has truly revolutionized the way we treat breast cancer, where we're able to use predictive biomarkers to determine the treatment they would get. I'm going to skip through most of this. And talk very briefly about two advances that are really transforming the care of breast cancer. The first one is this concept called minimal residual disease. So if you look at a patient who had breast cancer, who had surgery, who had radiation, and then they received some kind of a systemic therapy, the paradigm right now is, how do we follow them? We follow them essentially clinically, and some patients will develop metastatic disease, unfortunately, down the road, maybe years later. And the only time we find out is when the patient either has symptoms or they had a scan where we see visible tumor. So clearly that is already late, and most of these are what we call distant recurrences, meaning stage 4 cancer that has already spread to the liver or bones, things like that. Can we do better than this? And one of the things that is absolutely going to change all of cancer care is this concept of tracking minimal residual disease. That is, not wait until a patient develops symptoms or you find that the cancer has come back on a scan, but can you track this tumor molecularly? The way we do this is by figuring out specific alterations that are unique to the tumor, either mutations or other alterations. And once we know what is unique to the tumor, what you can do is you can sample your blood. And even when you have a very, very, very tiny amount of cancer in the blood, because you know what you're looking for, you can use some very sophisticated molecular biology techniques to do amplifications to even detect the tiny amount of cancer that may be there. So you can track that this cancer is coming back even before you have any symptoms, even before you can see anything on the scan. So hopefully the amount of cancer is so small that we can act sooner before this patient develops stage 4 disease and is incurable. So this is something that's going to happen across all cancers, and this concept of tracking minimal residual disease is going to take over cancer care. I think this is going to be absolutely fantastic. I'm going to skip through most of this. The last thing I'm going to talk about, the other advance that is really making huge progress in improving the care of patients, is this concept of resistance. So if you take stage 4 breast cancer patients, although we have exceptionally good treatments for them, one of the reasons why the breast cancer is incurable in stage 4 is because those patients become resistant to these cancers through development of mutations and other alterations that make these cancers essentially unresponsive. So the other advance that is really taking over is this concept of understanding drivers. Previously, we just used to have this list of therapies that you just go through. You treat them with one therapy. When they progress, you treat them with the second therapy, so on and so forth. What we're moving more towards is through understanding what the drivers within this cancer is, through sequencing of these tumors to understand the precise alterations that may be responsible for this, and to match those with treatments that are effective. So this is, again, a quick example of something we have done in our lab, where a mutation that happens in the estrogen receptor can cause resistance to common therapies. The mouse on the left is inoculated with cancer cells that have the normal cancer, and the two on the right have a mutation that is often developed in patients after receiving these systemic therapies, and that makes them completely resistant. We're able to do drug screens to identify new drugs that are effective in the context of these resistant mutations, so that we can essentially propose treatments that are specific to this mutation that is driving the cancer in these patients. So I think with that, we're out of time. I want to thank a number of people in my lab. I didn't share a lot of work that we did. I think this was mostly a clinical talk. But nevertheless, a lot of people in my lab who advanced this, a number of funding sources that have helped us, especially early on, my colleagues in the breast team, and more importantly, the patients that we have the privilege of treating, as well as for participating in the clinical trials that not only hopefully improves their outcomes, but also advances the treatments for many generations of patients to come. With that, happy to take any questions.
Thank you, Dr. Alluri. That was amazing. And we will definitely move to some questions. Our first question comes from BJ. BJ, you had a question for Dr. Alluri. You want to go ahead and unmute yourself?
Yeah, I was just curious about proton therapy for that left-sided breast cancer.
So the proton therapy, as of now, is still not standard of care for breast cancer. So there are some theoretical advantages, as you can imagine, for a lot of these newer technologies. And the gold standard for adopting any new technology in a more broader scale is to complete randomized controlled trials where you compare the newer technology with existing technology to show that there is in fact a benefit, and that those trials are still pending. So short of that, I think there are clearly clinical trials ongoing, and we have to wait for the results of those trials to determine if that becomes the standard of care.
Thank you.
Thanks. Our next question comes from Mary. Mary Whitmore, you have a question for Dr. Alluri. Hey, Mary, we're having a little bit of trouble hearing you. Not sure if the microphone is close enough.
I'm sorry, maybe it's because can you hear me better now?
Yes, much better, thank you.
Okay, sorry about that. I was curious about gamma pod requirements versus traditional treatments. For being treated on the gamma pod, I mean.
So the gamma pod is, as I had mentioned, is primarily for partial breast radiation. That is, in cases where we are only treating a small portion of the breast and not the entire breast. And not all patients are candidates for that. So typically, partial breast radiation is given for patients with early stage breast cancer that are not lymph node positive. The tumors are relatively small. So there's a lot of factors that make somebody, determines whether a patient is a candidate for partial breast radiation or not. And a lot of patients that are candidates for partial breast radiation can be treated with gamma pod. There are some technical issues, meaning the location of there are some locations of the tumor that may not be amenable for gamma pod. An example is that the tumor is too close to the skin. We typically don't treat that because we're giving a high dose of radiation. We don't want to cause too much skin toxicity. So there are some exceptions where, you know, not every patient who is a candidate for partial breast radiation is a candidate for gamma pod.
Okay.
But by and large, we have alternative approaches to treat those patients.
Okay, great. Thank you.
So our next question comes from your good friend, Dr. Alluri, and mine, Dr. Stu Ravnik.
Yes.
Hey, Prasanna, congratulations. Nice work and really nice presentation. So you mentioned stage 1 cancers as being small, but how many cancer cells is that? And how do we move the needle for actually detecting the microscopic cancers you're talking about?
Are you talking from a screening stage? Like
Yeah,
picking up
so
cancers?
yeah, when you're picking it up, you get a stage 1, it's small in a single
Yeah.
location. How
Yeah.
how do we get even better?
Yeah, so I mean, that is a huge area of interest as well. So this whole concept of minimal, tracking the minimal residual disease, well, this is not residual disease in this case, can also be applied for screening. The challenge, of course, is finding alterations that are specific to the cancer. And that information is becoming, you know, more and more available, right? With the large-scale screening, the TCGA project, where we have sequencing data from, you know, hundreds or even thousands of breast cancer patients. I think we have to come up with a catalog of alterations that are specific to the cancer that we can use to deploy for a screen that captures a large number of these patients. So I think this is something that will potentially be deployed in the future.
Great, and welcome back to Southwestern, of course.
Thank you.
Our next question comes from Stephanie. Stephanie, you have a question for Dr. Alluri?
Yes, thank you so much. Mine kind of goes back to the beginning of your presentation regarding the lymph node mapping, kind of getting to that Sentinel node. Is that done before other treatments or after their surgery and such that?
It's a very good question. So this is typically done at the time of surgery. You're asking a very intelligent question, because the previous paradigm used to be that everybody used to get surgery first and everything else used to follow after that, whether it's radiation or systemic therapy, so on and so forth. I didn't get a chance to go into all of this, but that paradigm has already changed. The vast majority of patients now actually get a systemic therapy before surgery. There are a number of advantages for that. One advantage is if a patient has a larger tumor, right, and they're not candidate to have the limited partial mastectomy or removal of only a part of the breast, you can give a systemic therapy to shrink the tumor to a point where you can still do breast preservation. That's one reason. The other reason is also sometimes patients have extensive disease, and shrinking the disease to a point where the treatments are less toxic helps the surgery. The challenge, of course, is when you give a treatment before surgery, that changes the lymph nodes, right? You may have cancer in the lymph nodes, and when you gave a systemic therapy, the systemic therapy may have removed or altered the cancer in the lymph nodes. And how do you now determine what's in the lymph nodes? This is, again, a very evolving area. Things are changing, you know, every year. But we still do sentinel lymph node mapping even after having a systemic therapy up front. For example, there are some patients who get a chemotherapy first, then they go to surgery, and they may still get a sentinel lymph node mapping. And if the nodes are negative, a lot of times we can avoid having to remove all the nodes. It's kind of a more complex answer. I'm happy to chat with you offline, but it's a very relevant question, and it becomes relevant again when we are treating with radiation before surgery. You know, how does it affect sentinel lymph node mapping? That is also something we're looking at.
Thank you so much. Thank you, Corey. Thank you, Jen.
Thank you. Our last question, because we are trying to wrap up, comes from Wendy. Wendy, you had a question?
Hi, Dr. Alluri. I was wondering, you talked about tracking the minimal residual disease, And I was curious whether when we see our oncologist and they measure our tumor markers, is that what they're doing? Or is that a separate process?
This is, the tumor markers that we traditionally use are not as specific, if you will. So the minimal residual disease is really a specific gene or alteration in a gene that is present in the cancer cells that is not present in your normal cells. So you have to imagine you're shedding your DNA into your blood, right? You have cells in your body, you're shedding cells, shedding DNA, and the vast majority of the DNA is going to come from your normal cells, right? We're talking about microscopic disease, so you're talking about millions and million-fold higher normal DNA than any tiny amount of DNA from a cancer that you can't even see. So what this requires is a specific alteration that now we can amplify and look, it's essentially a needle in a haystack. So the way when this is adopted would be when you have surgery and the tumor is removed, we can sequence the tumor and we can sequence the normal tissue to identify in this specific tumor what is an alteration that's only there. Then you have to develop an assay for that particular marker, that particular gene or mutation or whatever we identify. And then you just have to track it serially, right? So the way this you would expect is when you have the tumor in the body, the marker will be high. Once you have surgery, it'll fall. And once you have your systemic therapy or radiation, it'll be low. And it should just stay low. If you start to see that going back up, it's almost always an indication that the cancer is coming back, and you may be able to pick that up 6 months, 3 months, a year before you see something on a scan. And this may give us an opportunity to really cure it, if you will, before it becomes, incurable.
So is that being utilized in practice, or is that still in trials?
Still in trials.
Okay.
Very, very encouraging trials across the board in a lot of cancers. And I would suspect this will become, I think there's a lot of development that needs to be, happen and optimized. But I suspect 10 years from now, this will be how we'll be following cancer in patients, for sure.
Well, thank you everyone for the great questions. And I'm going to go ahead and pass back to Jenny to close us out.
Thank you so much. I agree. Really amazing questions. Such a smart audience. And Dr. Alluri, thank you for that tremendous presentation. Everyone knows someone who's been affected by cancer. Probably many of us know someone who's been affected by breast cancer. And so we're really happy to learn more about what we're doing here at UT Southwestern with you all. Share it widely. Everyone get their mammograms. Women, get those mammograms. Tell your sisters, mothers, daughters, cousins, friends. Let's do this. Let's get rid of breast cancer. We are going to be back in 2 weeks on Thursday, October 22nd with the next cafe, and it's going to be talking about the science of scars and healing with Dr. Benjamin Levi. The following Saturday, we've got some spooky science to kick off Halloween with a program that's called Science in the City that we do with our partners at the Dallas Morning News. We'll be sure to send all of our friends on the Science Cafe list information about that. Dr. Stu Ravnick on the call tonight. He is part of our tremendous planning group, and it's going to be fun. It's for all ages too, but if you guys have little kids or grandchildren or children, you need to, grown-up kids, have them join us. For now, please stay safe. We're going to send you an email. Send us your thoughts about the Science Cafe. Wear your mask. I'm going to put my RBG one on. Maintain physical distance when you're in groups. Try not to be in groups. Be outside. Stay away from people. Wash your hands. And we'll see you in a couple of weeks. Thank you so much.
Dr. Levi is awesome. So I also trained at University of Michigan, where he just moved from. So he's amazing. I encourage all of you to try to join if you can.
We're doing the Michigan alum each week.
That's right. We're going to cycle through them all. Dr. Alluri, thank you so much. Continued success with your research. We really appreciate you. Everyone, we are adjourned. Have a great night.